Okay, good morning everyone. So thank you for the introduction. As it says on the slides, I'm Lara Morison, Chief Strategy Officer, and accompanied by Dr. Lara Alloway, our Chief Medical Officer. And we were here this morning really to talk a little bit around where we are with our priorities and the work that we've been doing around our system plan, and then really to bring to life some of the case studies around that so that hopefully you can see some of the examples, and one example in particular, of how we're really looking to build on opportunities around research to embed improvement in our system. So I'm conscious we're probably a little bit behind time, so I'll do my best to sort of trot through some of these bits. So a bit of context for those of you who aren't aware, this is the Hampshire and Isle of Wight system. So the ICB covers about 2 million people, 1.9, so it's a large geographical patch. We've got our 4 acute hospital trusts, 1 community and mental health trust. We've got our trust that provides our acute and ambulance services over on the island, and we do have an island, which makes it a really interesting context to be working in. 139 GP practices, and actually we've undercooked our budget a little bit there. It's about 4 billion. So hopefully that gives you a sense of the breadth that we're on, the footprint that we work with, and the opportunities, therefore, that we have within our patch. So just in terms of a high-level overview of our strategy and the work that we've been doing around something called our renewed ambition. So back in 2022, along with other integrated care partnerships and integrated care systems, we developed our strategy, our integrated care strategy. And that developed and agreed with our local authority partners, with a range of health and care partners across Hampshire and Isle of Wight, our 5 priority areas that we wanted to focus on together. And these were the areas where we thought we could do better at scale, working together, and we're really specifically clear that this wasn't cutting across all of the important work that people are doing at place. So as we've gone through all of this process, we've tried to make sure that working at system adds value in addition to all of the work that happens with those local relationships and work. These are our 5 priorities across our strategy. So this is the broadest sense of the work that we're doing. So mental well-being, children and young people, good health and proactive care, data and information, and workforce. And beneath all of those, we've got the specific priorities that we are working through. Then the development of our joint forward plan moved into something called our renewed ambition. So I think what we were conscious of was that it's great having very high level priorities and some specifics underneath that. But for the NHS system, what is our commitment that we want to be able to demonstrate to delivering those and how we want to work together? So we did quite a lot of work at the start of last year and through into the summer to articulate some commitments that we wanted to be held accountable for in terms of how we did that. So a focus on the fact that we will make a shift towards proactive and preventative care and support. We are absolutely committed to delivering the person-centred care, and really importantly underpinned by the community approach to well-being, so thinking as much as we can about that wider resource and resilience in the community. Maximising our pathways of care and essentially making sure that that is delivered off data and use of clinical outcomes, and seeing all of the work from CEG just now was great, because that is also about how we move into practice and thinking about all the approaches we can take around that. Maximising use of resources in our system, and you can see from the previous slide we've got a lot of those, and thinking about how we collaborate and integrate around that. And really importantly, we wanted to be explicit about the fact that we want to be a learning system. So we are dealing with lots of complex and complicated challenges. There's a real value in committing to how we want to do that, how we want to learn, and how we want to improve together, because we won't get the right answer first time around, but giving ourselves as a system permission to try, improve, and learn is really important. So bringing those commitments and those priorities together, just a quick sort of run through where we are 1 year on from that. We've made a commitment and a sort of quantifiable commitment to left shift and working through really a shift of resource, albeit in the first instance relatively small, but it is ring-fenced resource to ensure that we are developing all of those key priority services that we've identified in community settings to start a multi-year programme to left shift. So it's the start of a journey, but actually in the context of significant financial challenge, that does feel like quite an achievement when we're looking at a year-on-year process, and I'm sure people will be aware of the sort of planning rounds that we've been through. We have allocated specific resource around that, built on all of the work I've just described. We've identified system signature moves to really make sure we're able to demonstrate impact. So we've identified CVD and frailty as being areas that we can work on at scale with our providers, with our partners, to start to build what the solutions to some of our problems are across really making sure that people are having the care, receiving care in the right place at the right time, which we know doesn't happen as consistently as we would like it to, and looking at how we make sure we deliver in-year impact from that. So again, that start of the journey where we're able to demonstrate improvement. Really importantly, building the models of neighbourhood working. So I know, I'm sure people here are really familiar with the concept of things like neighbourhood teams. So we've got our focus on what our neighbourhood teams look like, but also going back to that piece around community, what the broader neighbourhood working geography needs to look like, and how we make sure that both we are making use of the NHS and the local authority and the statutory services, but really importantly, thinking all the way through how are we making best use of all of those resources that are available in the community to think about how we get best value and best impact for our residents. Embedding population health, analytics and insight. So that's been a really important theme through everything that we've done. Those priorities that I talked about, CVD and frailty, they are all driven off the fact that we've got that population health analytics that tells us where we might want to focus, thinking about inequalities, how we really focus down on those areas where we want to start that journey, and making sure we're embedding that into the processes of how we're making decisions and how we're really being able to quantify the shift of where we are now with resource to where we want to be. And I know Faye, who's leading our team on that, will be on a panel later as well. And then also building our framework for strategic commissioning. So all of the things that I've touched on in terms of understanding our population needs, quantifying our outcomes and impact, thinking about how we make sure we've got the right service design and collaboration, building that all now into a framework of how we want to do business going forwards as an ICB, and being the strategic commissioner in the system. So hopefully that gives you a bit of a sense of sort of where we are now, some of our key priorities, and a really core theme on this as well is about how we work together and how we've been working together differently and building some of those sort of commitments across our communities in Hampshire and Isle of Wight. And at that point, I'll hand over to Lara.
Thank you, Caroline. Good morning, everyone. Great to be here. So, yeah, just picking up on how we are starting to work differently across our system. As clinicians, we really wanted to make sense of all the different strategies, policies, and really think about how we were going to look differently at the way we work together. So back in November 24, after a lot of work of bringing it together, we launched our Hampshire and Isle of Wight clinical framework. So our clinical framework, you won't be surprised to see, has the quadruple aim. And Shera mentioned the IHI triple aim, and we've added in the experience of providing care here as well. So absolutely, to make sure we have simultaneous, fair and balanced improvement of health and healthcare outcomes that matter to people, the experience of receiving and, as I said, providing care, as well as effectiveness and efficiency in cost of care, underpinned by reducing inequalities and improving population health. So our clinical framework is really the principles and values which will underpin the way that we plan, design and improve the healthcare services that we deliver. So along the top it has, if I can do it, the renewed ambition statements that Caroline read out. So we're trying to pull everything together. And then we've got these groups that we think are really important about how we work. So intelligent care, being evidence-based, data-driven, value-based care, making sure that it's absolutely the equitable, sustainable and transparent use of the available resources to get those better outcomes, and safe and connected care, right care in the right place at the right time by the right person. And then we've got more detail about how we're focusing on these, but underpinned by actually our workforce, developing, supporting and valuing our workforce to meet the changing needs of the population. So, and as we said, we are a learning system. So research and improvement, innovation are key to everything that we do. Now, I'm really glad I didn't use the case study of our CVD signature move that Caroline mentioned earlier, because I would be embarrassed that we are not the best in the country. In fact, we are in the worst decile, which we are not proud of. Hence the need to focus on that for us and think about how we do things differently. But actually, what I was going to talk about is something that we're proud to be part of, which responds to the inequalities that we know exist in maternal outcomes. And you'll be familiar with these statistics, I'm sure, that actually there has been an increase in maternal death rates. And when you take out the COVID effect, that's still a 31% increase over the last 5 years. And as you know, that is more significant in global majority populations and in more deprived areas. So back, I had to check actually on my phone that it was the last Health Secretary, because we've had so many, haven't we? But Victoria Atkins, in January 24, the last Health Secretary, announced that actually there was going to be funding through the NIHR to really think about this. So the first NIHR challenge. And we were delighted to be approached by Southampton colleagues, by Keith Godfrey, who many of you will know, and there are many people involved in it in the room. And it's great to be part of it. So there was the maternity disparities call to bring together a diverse consortium of organisations. And we actually are the only consortium that have included ICBs. So we're working with Luton, Dunstable and Milton Keynes ICB, University of Southampton and UCL. And now some Northern Ireland colleagues have joined as well. And it's fantastic to actually think about how we are going to build the capacity and capability in our system for approaching this with actually delivering change at the same time. This is evolving really quickly. I've learned a huge amount in this process at quite how chaotic it can feel at times around these bids and things. And it's quite reassuring. It's very similar to NHS planning. But so we are trying to co-design, co-implement and co-evaluate care and support before and between pregnancies to reduce maternity disparities cost effectively and at scale. And the different populations from Luton, Dunstable, Milton Keynes, and then thinking about ours across Hampshire and Isle of Wight, and now in Belfast as well. We've got a real opportunity to think about different groups. But this does, as you'll see from the slide, come down to setting up community-based researcher positions and actually co-producing this with our population. So we look forward to coming back and talking to you more about what we've achieved together, but I'm really clear that this is about bringing our clinicians, our commissioners, our researchers all together with our population to really make a difference. So I think I'm now handing back to William.